Assalamu alaikum. Hello, everyone, and thank you for joining us for the panel discussion on understanding of the private health sector in the Eastern Mediterranean region, which is actually as a part of the RC68 marketplace event in October, within like a month from now. My name is Hassan Salah, and I'm the primary healthcare regional advisor for in the regional office, and I'm the team lead for the access to health service in WHO EMRO. Our agenda today will start with a brief presentation on the topic of our panel, and then we'll follow with questions and answer to our colleagues from the panel member. And this is going to be from 5 countries, including our colleagues from Iran, Jordan, Libya, Oman, and Pakistan, and of course our colleagues from the United Nations sister organization, including UNICEF and UNFPA, as a part of the GAP Accelerator 1 for the primary health care. First, I would like to welcome and introduce the panel member alphabetically. Dr. Ahsan Mokbal is a senior technical officer from Pakistan Ministry of Health. Dr. Anas Muhtasib, and he's a family medicine and health economist specialist from the Ministry of Health in Jordan. Dr. Ardishal Khosravi, head of the health statistics and health economics in the Ministry of Health and Education in Iran. Dr. Ghassan Karim, director of the Primary Health Care Institute in Libya. In addition, of course, Dr. Mazen Al-Khapouri, he is the Director General of the Private Health Establishment, Ministry of Health of Oman. Hopefully, he is going to join us soon. And our colleague, Dr. Mohammed Afifi, is a reproductive health and humanitarian program specialist in the Arab States Regional Office in UNFPA. And last but not least, our dear colleague, Dr. Tomomi Kitamura, Child Survival Development Specialist from the Regional Office of the Middle East, North Africa, UNICEF. Let us start first with a presentation from Dr. Aya Thabit on the study overview and the scope and the methodology. Dr. Aya is the EMRO focal person for the private health sector. Over to you, Dr. Aya, please.
Thank you,
You
Dr.
can share your screen, please.
Please let me know when you start seeing it.
It's visible. Right.
Okay, thank you. So as Dr. Hassan mentioned, this presentation will just give a quick overview then on the study, then we will open the floor for the panel discussion. So basically, I will just give an introduction. So first, I'd like to start off by defining what we mean by the private health sector. The private health sector in general includes all non-state entities, individuals, and organizations whose primary purpose is to promote, restore, or maintain health. In the context of service provision, the private health sector includes individuals and organizations that are neither owned nor directly controlled by the government and which are involved in the provision of health services. These include for-profit, not-for-profit, formal, informal, domestic, and international. The private health sector is exceptionally significant in the Eastern Mediterranean region. In a recent assessment, the for-profit private sector has been estimated to be sought for the provision of 53% of inpatient services and 66% of outpatient services. The private health sector is thus considered to be a major stakeholder in the provision of health services in the EMR. In 2018, member states endorsed a resolution on effective engagement with the private health sector for UHC. The resolution has further requested EMRO's support in conducting assessments to identify challenges and opportunities related to the engagement of the private health sector and to develop strategic action plans for the effective partnerships towards UHC. Accordingly, we have developed an in-depth assessment of the private health sector in the region. The assessment explored different areas, including the operational environment of the private sector with respect to governance, financing, health information systems, PHS resources, service delivery, quality of services and oversight, as well as the legal and operational environments for private-public partnerships. The methodology of the study involved desk review followed by expert interviews to address the information gaps that were detected in the first phase, which is the desk review. And we had 19 countries in scope. 2 of them are still conducting their assessments, and 17 have already concluded their reports. So this brings us to the panel discussion and the objectives of the panel discussion. So the main objective of today's discussion is to go through the key highlights of the assessments done in the Islamic Republic of Iran, Jordan, Libya, Oman, and Pakistan. That's all from my side. Over to you, Dr. Hassan, for moderation.
Thanks a lot, Ayan. Thank you very much for your brief presentation. Let us move now to the question to our colleague from the panel member. And my first question is directed to Dr. Anas Al-Muhtasib. As you are a healthy economist and from the financial perspective, do you think that the for-profit private health sector has a role in achieving of universal health coverage, if we are talking in Jordan in particular? Over to you, sir.
Okay, thank you. So interesting question, really, and maybe the answer is yes and no. Definitely, the private sector has a role in UHC as it has the financial ability to provide the infrastructure required for service provision. However, being for profit contradicts the concept of UHC and the idea of that the health is a public good, not a profitable service. The main source of income for private institutions in many EMR countries, according to the report, including Jordan, is out-of-pocket payments, which is usually from residents. So high out-of-pocket means high risk of catastrophic and impoverishing health expenditure, which is against UHC. It also means an inefficient use of resources because these available funds could have been used more efficiently and equitably if paid as premiums for a large-scale insurance scheme. If you added to that the drain of specialized health workforces outside the public sector, as the case of Jordan, because of the stark difference in income between the private and public sectors, this leads to poor quality services at public sector and unmet needs, which again drives patients to use the better services equipments at private sector, again with higher out-of-pocket expenditure in what may seem as a vicious circle. So again, leaving the private sector to work alone without strict regulations is an unfortunate formula for causing healthcare system failure and drives us away from achieving the goal of UHC. Is it possible to regulate it in the context of free governance in EMR countries? According to the report, there's weakness in the governance in EMR countries. So are we able to regulate it? I hope that, although I doubt. Furthermore, if we are able to regulate it, are we able to finance it? It will notice that health expenditure grows faster than the GDP growth locally, regionally, and globally, which threatens the sustainability of healthcare financing. The fiscal space for health is limited, and we have to think how to maximize the benefits from these limited resources from both public and private sectors. So, for example, during the second wave of COVID-19 pandemic in Jordan, while demand for oxygen increased significantly, the Minister of Health exempted liquid oxygen from sales taxes at private hospitals, provided that this will be reflected lower fees paid by patients. The question is, why not to generalize this idea to all inputs of health services delivery at all sectors during all times? By this, we can decrease the cost, the fees, which could reflect on lower out-of-pocket payment, which is aligned with UHC goals. Otherwise, the patient pays high out-of-pocket, which is taken from the service provider as a profit for service provider, and the government takes taxes from service provider and takes part of this tax to give it for the patient, for poor patients. Some of them are not taking this money because they are avoiding the public sector for poor quality and goes again to the private sector. So maybe the same patient who pays the out-of-pocket, the government is taking this out-of-pocket to pay it for him, but he is not taking them actually. So in fact, I am keen to endorse the concept of not-for-profit principle applied in Japan for both service provider and insurers. I feel that we can incentivize the growth of non-for-profit private sector, especially hospitals, with ceiling of income, exemption from taxes, and priority in governmental contracting, provided that we use the right tools and long-term policies. This can be done gradually over 5 to 10 years, and at this time is the best due to financial difficulties that faces the private sector after the pandemic and diminished medical tourism over the last few years. This way, the private sector will be able to play a larger role and a positive role in achieving universal coverage. Hopefully, I answered the question.
Thank you, Dr. Anas. Yes, I totally agree with you when you started your answer. Yes and no. Yes, in terms of expanding of the service through the, the private health sector, definitely will reach to the 3 dimensions for the universal health coverage UHC thing. But in the meantime, strong regulations, strong governance needed for this aspect. Yes, thank you very much. Let us move to Iran, and as we may already know that actually Iran, they have an excellent model for contracting with private health sector, one of the unique countries in our region. And my question to Dr. Khosravi, what type of payment system is the best for outsourcing the family physician program at the primary health care level in Iran? Over to you, sir.
Yes. Thank you so much, and thank you for this opportunity. Actually, as you know, there is a different mechanism for the payment, especially in the family physician in Iran. There is a different mechanism. But for example, we have per capita method, we have fixed salary, we have fee for service, and also there is a mixed method that we can use for the payment of the physician or family practice. You know, each of these mechanisms have advantages or maybe disadvantages. So the appropriate method is we use, and we are using a mixed method in Iran. Because, for example, if you suppose you wanted to use per capita, although the per capita is good because you have a good coverage of people and defined population can register for getting the services, but it doesn't motivate the provider to have, for example, to give the services to treatment and something like that. Another mechanism may be fee for service. This is another mechanism that we can use, but the disadvantages for a fee for service maybe is induced demand. So this is another method, but this has a disadvantages. Or maybe fixed salary. This is another mechanism for payment, but this is not very productive in the payment for, especially for family physician when you wanted to have a contract with their family physician or family practice team. So the best mechanism for payment that we are using and is based on the pay for performance is a mixed method. We have a per capita, one mechanism, and fee for service. So, and we also have a bonus based on reviewing the performance of the family practice. So this is the situation that we can use a productive mechanism for payment, and we are using and many evidence and review of some articles that have been done based on research in Iran. They suggest that the best mechanism for payment in the family physician program is using a mixed method.
Yes, thank you, sir. Thank you very much. This is very brief conclusion for, I have been in Iran a couple of times actually, and I visited the family physician clinics, and I really see the whole things in the ground there, and it's really very good model how you are mixing in the contracting approach things with the private health sector and putting in consideration the quality of the service. This is the key of the whole dilemma there. Thanks a lot, yes. Dr. Khosravi. Let us, thank you, sir. Let us move now from the country's perspective to the program perspective. Let us talk about that. Yes, yes, sir. Dr. Khosravi.
It was echo. Sorry, I just mute that.
It's all right. It's okay, sir. Thank you very much. Talking about the child and the child health perspective things, and my question to Dr. Tamoumi, what are the challenges and opportunities could be addressed by the private health sector in primary health care, especially for the universal health coverage? Over to you, Dr. Tamoumi, please.
Thank you so much, Dr. Hassan. Thank you for having me in this among the beautiful panelists. So I guess, as you know, that the primary health care is recognized as the main strategy to reach universal health coverage. And then primary health care is a vehicle to provide not only health and nutrition and care and services, but also for addressing the health and well-being of women, newborn babies, children, and adolescents who require additional services with quality. Countries in the region have existing package of essential health services and deliver them through primary healthcare system to achieve universal health coverage goals. In the Middle East and North Africa, most of the care seeking of common childhood illnesses like diarrhea and pneumonia happen in primary healthcare facilities, and around 20 to 30% care seeking takes place in secondary health facilities. We see a trend of poor-rich access to care seeking in the private sector and poor access in the public sector. We also see people tend to access to hospitals for treatment of childhood illnesses as they perceive secondary care to have a better quality. Based on this reality, the latest data shows that between 2013 and 2014, 47.3% of under 5 children sought care for diarrhea from a health facility or provider, and only 26.7% of children received oral rehydration salts. So contribution of the private sector are vital to increase the coverage of essential maternal, newborn, and child health services with quality. And then also the region is also known for high proportion of children experiencing violent discipline. It's around 87% of children between 1 to 14 years old. So and also data from several countries in the region shows the average of 33% of children at risk of poor development. So we also need private health sector engagement to ensure responsive and nurturing care for children, not only to survive, but also to thrive for the better development outcome. So hope I answer your question. Over back to you, Dr. Hassan.
Thank you, Dr. Tamoumi. Thank you very much for this brief. Let us move to the biggest country in our region, Pakistan. Yes, definitely, it is the biggest one, almost 200, actually exceeded the 200 million now. And Pakistan, as you may already know, that they already endorsed the essential health service package with its interventions. And my question to Dr. Ahsan Maqbool, what are the options for engagement with the private health sector to provide and to implement the essential package of service, given the situation in different provinces in Pakistan? Over to you, sir.
Thank you, Dr. Hassan, and good afternoon, evening, and morning to respective participants. I think engagement of private health sector is something that has been going on in Pakistan from the last few years, since 2016 now. But that has been segmented across specialized care services, and that also for a select number of diseases which carry a high burden. So high out-of-pocket expenditure diseases were actually focused in this scheme. So the last 5 years, we've seen that the private and the public sector providing the specialized care for 9 select conditions, and those requiring interventional techniques like bypass grafting surgery for cardiovascular diseases, regular dialysis for kidney failure or chronic renal failure patients. So there are 9 conditions for which the private sector is already empaneled across the country to provide these services free of cost to the recipients. That free of cost service is definitely defined through a poverty profiling of the beneficiaries, and based on that poverty profiling, Pakistan has a national database that links up with that status and also the provision of services. And then the health insurance phenomenon kicks in which the government provides the procurement cost of the services to the providers, while the recipient has little or no out-of-pocket expenditure. So that has been pretty much tested and now spread out across the country for the tertiary or the specialized care. Recently, with the support of WHO, we are also pilot testing the procurement of services for primary healthcare through general practitioners in Islamabad Capital Territory, and it has just recently been launched about 2 weeks ago. And the essential package of services, which is quite heavy in terms of its component around the community level platform and the primary healthcare level platform of delivery of services, is something that we are now focusing on based on the endorsement of that package by the country. In that mechanism, what the government realized was that since preparing the health system and expanding it according to the increase in the population, there are a lot of entities in which you not necessarily now need to develop infrastructure on public expenditure, but employ the services of the private healthcare providers, especially GPs in that locality, on given terms of reference and engagement. And similar to the specialized care phenomenon in which procurement and services for private care for interventional sort of treatment modalities is now being tested for the primary healthcare, primarily outpatient-based consultations and follow-up of care and continuum of care. And secondly, then we are also trying to link it up with the routine health information system that is going to report in terms of the number of patients treated for a certain type of condition, and that will also strengthen up the disease profiling in the country as well. Besides that, there is going to be besides a reporting linkage, there's going to be an active, continuous medical education sort of phenomenon also linked up with it through the higher body of the government. So those GPs who are assigned, let's say, a certain set of notifiable diseases to be reported, as well as to be treated, and for continuum of care, as well as for the procurement of services, they will lift up into a broader, larger database in which they are directly linked up with the public healthcare system. But they do have this fee-for-service sort of mechanism in which the patient does not have to pay out of pocket. So those are the themes and areas in which we are working under the EPHS, or the Essential Package of Health Services, and it's laying out across the primary level as well as maybe to a greater extent in the coming days at the community level through the private sector for procurement of services. Thank you.
Thank you, Dr. Ahsan. Actually, Pakistan, one of the 3 countries, in addition to Sudan and Palestine, who are working with these 3 countries under the umbrella, of course, for the already endorsed essential package to identify the model of care. And this is one of the biggest initiative for us as a regional office to support the countries, in which they are going to identify how they are going exactly to deliver this package, including the governance components, the finances, the human resources, the information system, the technology, everything. So I guess we are in a very good progress in this. And the first part of this initiative, the first phase, is going to end by June of the 2022. Let us move to our colleague from Oman, which actually they are representing one of the GCC countries, and Dr. Mazen with us, Dr. Mazen Al-Khaboui. Thank you very much, sir, for joining us. And my question to you, what the roadblocks are affecting the public-private partnership route in health service delivery in Oman? Over to you, sir.
Assalamu alaikum.
Alaikum.
Actually, I've been with you since 3 minutes before the opening, but I had gone to the link which was given to me by the Google Calendar, which was, I think, then I went to, anyway. So thank you very much for allowing us to participate. Actually, EMRO is a very diverse region where you have, I don't like to say it, extreme poverty and lack of services, and then you have the highest available facilities. And I don't know where Oman is, but at the moment, His late Majesty, when he came to power in the 70s, he promised free health for all country. And I think the same policy has been with the other GCC countries. So the major roadblock to public-private partnership and the flourishing of private health services is the excellent services provided by the government sector. And I was in a meeting today just now with all the private hospitals and the healthcare providers, and I was giving them a talk that why don't you add value? Because whenever there's a problem, the patient gets shifted to the government sector. They cannot, and since it's free, how can you compete? How can the private sector compete with the government sector when the government sector promises free healthcare delivery, universal healthcare coverage? So we try to encourage, we try to push the private sector to develop. And one of the pushing points was we said all expatriates initially not working in the government sector have to go to private. So this encouraged private sector to open hospitals and to cater for the expat community, which is a significant number. It's about 43%. So it's a huge amount. And this was to encourage the private sector to develop. And we have developed significantly from 0 hospitals to now we have more hospitals than the government sector. Less number of beds, but more hospitals. But it's been that we need to encourage the private sector or the government sector to reduce the amount of services or where there is a long waiting list to go into the private sector, which is happening now. Like cardiac bypass services, we are encouraging, since I'm also in charge of private sector in the government, I'm encouraging private sector to develop cardiac services, which is the biggest, highest morbidity and mortality in the country, to do that. And we are trying to encourage them to open. The other roadblock is that Oman is a huge country. We have from south to north 1,000 kilometers, and some of it is very sparsely populated. Hardly, enough people for a private sector to sustain growth. And on top of that, the government is there. They have excellent primary healthcare centers. So how can you develop healthcare there where the guy says, I cannot, nobody is there. How can I? So they try to concentrate on areas where there's huge number of population, especially the expatriate population. So you will see in Muscat the largest number of hospitals and the largest number of specialized centers, because that's where most of the 75% or 60% of the expat population is. So the distribution of that, plus the government is so used to looking after the health of the whole country that their still psyche is the private sector does not exist. It's so, it's like a big giant with a small mosquito. They don't feel it. They don't feel the need for it to legislate for. I'm trying my best to develop PPP services. I was the advisor to the minister. I'm an ENT surgeon, by the way. Advisor to the minister from 2010 to 2015. Then he asked me to take over the private sector to look after it. And I developed a lot of PPP initiative. One of it was the renal dialysis, outsourcing it, because the rate of growth of renal patients was faster than we could build publicly. You know how public takes a long time for them to make a gas center. So by the time we build a center, you need another center. So I'd encourage the government to build centers and outsource it. But there was a lot of suspicion, lot of mistrust. Even one of the pharmacists on a big panel with the minister was there. He said, Dr. Mazen, they might sell the erythropoietin. I said, if they can spell erythropoietin, I will pay for it. They can't. How can you sell erythropoietin? Or anyway, the suspicion is there to reduce the amount. And what we have, and you know, we have the tendering system that everything goes to one person. We are trying to reduce that. What we are trying to do is now encourage tendering to get a, what do you call it, a benchmark fixed price, so that we say, this is the price we'll pay. Anything extra you take from the per patient. But so we are trying to benchmark or fix price, fix the cost. But we are the major roadblock, Dr. Hassan, is the mistrust. At the moment, they think the private sector is there to make money, and they don't care about ethics or anything else. This is the first barrier to overcome, to tell them that this is a partner, and it's 40%. So you cannot ignore it. So if you ignore it at your own peril, so the message is coming through. The minister is on board with us. It's just the lower people who are doing the day-to-day service, they need to be convinced. And slowly, especially with the pandemic, it was a good thing, because the pandemic showed us how the private sector could join the government center, because the government services were overwhelmed. They could not cope. The first thing they told me was, Dr. Mazen, can you find us a lab who can do PCR? Because there was one big PCR lab in the country. The rest were all point of care. So I developed PCR services in the whole country by encouraging them, calling Jordan, you have the Sultan Laboratories. He's a friend of mine. I phoned him. I said, can you exchange? So we built up a lot of, now the majority of PCR is now done by the private sector. So this encouraged us. We encouraged them to open ICU beds, COVID beds, and that has shown the government that the private sector is a major stakeholder, and it's a partner, and we have to work with them, unless otherwise the services in government sector will become overwhelmed. The waiting list will be long, and they will have dissatisfied citizens and other people. So I hope this answers in a short time my major concerns in the roadblocks to the government sector, especially in the country.
Thank you, Dr. Mazen. Thank you very much. Yes, I totally agree with you. It is this kind of mutual mistrust between the government with the private and with the private to the government. I mean, the private always under the impression that the government would like to take taxes, and that's why there is no any kind of official reporting things. The government on the other side, they always under the impression that this private is always looking for revenue, for profit, and that's why there is always this kind of mistrust between both of them. And again, I agree with you that our region has multicultural things, if we are talking about the private sector. And even if we are talking about the situation in our region, I mean, look what happened, for example, over the last couple of weeks in Afghanistan. And so anyway, talking about the situation in different countries in our region, our colleague in Libya with the post-conflict situation, Dr. Ghassan Karim, my question to you, sir, how we can improve the engagement with the private health sector in a country like Pakistan with a situation there, which is more or less kind of post-conflict setting? Over to you, sir.
Thank you, Dr. Hassan. I guess, I mean, naturally, neighboring conflict has a spillover, especially in Pakistan, has seen the spillover for the last 40 years now, since the Russian invasion in 1979, and then now the more recent one. I think this is Hassan Ahmad, so you want me to respond to that, or?
No, the question it is directed to Dr. Ghassan.
Hassan, okay, sorry.
It's fine. We can use Dr. Hassan's experience here as well.
All of us colleagues, yes. Thank
you very much.
Thanks so much, Dr. Thanks so much, Dr. Hassan, for giving me this opportunity to meet all the experts here and all the colleagues and learn from them. I can see that you are still enjoying your famous communication skills, sir. Thank you so much for this question. And yes, it's a quite important one. And I will start by saying things similar to those were mentioned by my colleague, Dr. Mazen. He was mentioning that how sometimes people, they look at private sector as a competitive partner, and it's more about not partnership, but maybe more about competition among public sector and private sector. But I think the first point is starting with the advocacy part. Because if we can raise the awareness and change the concept in the mind of decision-making leaders at the country, so they can see the private sector as a partner, that's the first step. Because I think universal health coverage is not about extending the public sector, because public sector cannot address all the needs. And even if it was possible for a while, it's not sustainable. But I think universal health coverage is about finding the right mechanisms to engage private sector and to build the private and public partnerships. Then secondly, I think it will be really important if we can enhance information sharing and transparency among private sector and public sector, because many services are delivered at the private sector part, and that's very important for the Ministry of Health and for policy making leaders, so they cannot build up their policies if they don't have enough information about the private sector. And one of the colleagues raised the issue of quality of care. And yes, sometimes the private sector, they have maybe more human resources, but we are not really sure if the quality of care is better at the private sector. And there is a big debate among different studies, and in the literature you will have a big debate about if the public sector is having more quality of care or the private sector. And then what was one of the maybe good learning lessons from Libya is that when even though the situation is fragmented in this post-conflict context, but when the private sector, they start having their, let's say, body. So we have what we call the Libya, the Private Clinics Union, or the Union of Private Clinics. So all of them, they came together to formulate one union so they can talk to the Ministry of Health, and even the ministry can engage them, because you cannot meet, let's say, hundreds or thousands of private clinics. You know, in the last decade in Libya, there was a 70% expansion of the private sector, according to the last survey. And that's, like they said, when the team, they were conducting the survey, they said every day when we finish one street, the next day we will discover that there is a new clinic in that street. And it was really difficult, to count all the private clinics. But now with this union, we can at least meet the people who represent the other private sector components, or the other private sector clinics or hospitals. And we can discuss with them, and they can participate in the planning sessions, in brainstorming. They can also participate in assessments and surveys and in strategies and in making action plans for the health sector in the country. And I think this was very, very, very important, because it's not only improve the communication and cooperation between public and private sector, but also it's helpful to use the private sector resources to move forward towards universal health coverage. And it makes them accountable, let's say, because the private sector, they need to know, yes, they need to be regulated, but also they are responsible. They are a partner to reach universal health coverage, and they need to think like that they are also responsible for this with the Ministry of Health. I think those were the main points that we learned from the Libyan experience, and that I wanted to share with my colleagues. Thank you so much, Dr. Hassan. Over to you.
Thank you, sir. Thanks a lot, Dr. Ghassan. Last but not least, our dear colleague, Dr. Muhammad Afifi from UNFPA, and our question is about between the private health sector and the sustainable development goal. And the question is, How do you see the role of the private health sector in meeting the relevant sustainable development goal indicator? If we are talking in less than 10 years now, we're talking about sustainable development goal for the 2030. Over to you, sir.
Thank you very much, Dr. Hassan, and thanks to all colleagues. Actually, it's very difficult to come after all these great interventions from the esteemed colleagues and panel discussants. But I will try to be very brief, and I'm happy that you mentioned the Sustainable Development Goals, because in 2015, when the SDGs were launched, all governments in our region subscribed to it. And it brought with it the principle of leaving no one behind, which highlights that health is a human right. It's not an option. We as development partners, as governments, as private sector, as international development agencies, have to be committed to fulfilling these rights, specifically the health right. And in our region, as one of the colleagues was explaining, we have huge diversity. We have countries that have very poor health indicators, for example, maternal mortality in hundreds, and we have countries in the GCC that are having great indicators similar to what European and Western developed countries are having. So we have this huge diversity, and we need to be aware of it to reach to everybody, leaving no one behind, since all governments committed to it. A key component of reproductive health that is at the core of UNFPA mandate worldwide, and it's a regional priority as well, is to improve family planning and maternal health services. If we look at the indicators related to these that are included in the SDGs, we aim to reach universal health coverage for sexual and reproductive health, meaning that women in reproductive age should have access to family planning services, to counseling, to antenatal care, to postpartum care. We need to address all these services and to reach out to everybody. But the question is, can governments alone do it? The simple answer is no. Here comes the important role of the private sector. And let me share with you two successful examples from our context in Yemen and in Syria. With the difficult ongoing situation and the conflict, we worked with midwives to support them to establish their own private midwifery clinics at the village level, because these are remote areas that the government has difficulty to reach to, and service providers, it's difficult to mobilize doctors and nurses and midwives from the capital or from the urban areas to go to these places. With small investments, with midwives who work in those remote villages where they originally came from, they established successful midwifery practice. Another example was with local pharmacists who are a sort of the private provider there, and in several villages, they are the only health provider in this village. What did we do with them? Because they are de facto health advisor. In absence of any health professional in the village or these remote areas or in the mountains, the pharmacist or the salesperson in the drug shop is the health advisor. They listen to him or her and follow their instructions, whether it's correct or not. Here comes our role to reach out to those people, invest in their education, and also in the case of reproductive health care, to provide them with family planning methods. We provided them with the contraceptives, so they were able to provide the correct advice to women who came to seek their advice, and also to provide them with the right commodities whenever it is needed. What do we need to do? We need to ensure that we have a win-win mentality. Colleagues spoke about the mistrust between the government and the private sector, which is understandable, and it's there in most of the countries. And we need to work on a behavior change strategy. We change the behavior of the private sector to know that government is not necessarily against you. Yes, they need to improve quality, to have legal oversight, to be accrediting you and licensing you, and to get taxes. We understand this as a role of the government, but also we understand the motive of the private sector. They need to make money. They need to have better status in the society. They need. So if we consider the needs of both parties and working with both parties together at the same time, we can reach a win-win situation. And there are several successful experiences in several countries worldwide that we can learn from and invest in. Another example we did in Jordan to help the Syrian refugees was the voucher system with the private sector providers. So there are several modalities that we need to think of and to be more innovative. We have to adopt innovative approaches. Private sector is more flexible than the governments. They tend to be less strict in their ways of thinking. Governments are controlled by the policies, the constitution, but private sector is more flexible, more innovative, faster in moving and responding to health crises and to emerging situations. So this behavior change approach to both sides of the equation, private sector and government, and also adopting innovative thinking and making sure that we have systems in place to bring in and to highlight to private sector that we need you and you need us, and together we can both move forward and to reach out to those who are hard to reach, so all women and girls and young people can enjoy and have access the right to the basic reproductive health care as a component of primary health care. Thank you, Dr. Hassan.
Thank you, Dr. Afifi. Thank you very much. It's a really very good discussion from the whole panel members. I really appreciate it. As a closing remarks from my side, over the last few days, we conducted two panel discussions again about the private health sector. The first one, it was about the role of the private health sector in COVID-19. And the second one was about the role of the private health sector in the provision and the maintaining of the essential health service. Today, over like maybe a couple of hours, and we will continue after this panel, we are preparing in a joint collaboration with the headquarters a training course. Mainly it is directed for the policymaker. Again, it is about the private health sector and how it is really very important to go for engagement with private health sector. All this kind of activities, it is going on because actually our region, for the Eastern Mediterranean region, it is the highest among all the WHO region worldwide in the role of the private health sector for both of the outpatient and for the inpatient services. That's why we are trying our best to encourage the policymakers in the ministries of health to go for engagement with private health sector. UHC service coverage, universal health coverage, the UHC service index in our region, it is in the range of 57. This is the average. And to go beyond this, no way that we will rely only about the public sector. The private sector has a major role in this. And the current pandemic is actually give us a good opportunity, excellent opportunity to go for effective engagement with the private health sector. Thank you, colleagues. Thank you very much for the wonderful panel discussion, and goodbye.